Thank you very much for the kind invitation, and I'd like to thank the organizers for inviting me here. I have been coming to Bangladesh now for more than 10 years, and there has been so much difference here over the last decade. Today, I've been tasked to give a little speech on the management of localized HER2 overexpressed breast cancer, and I have a timeline to hold, and I have to finish this in 25 minutes. You know, with the advent of internet and Google and international conferences that can be delivered through webinars, much of the data that I can present here is Googleable, meaning there is nothing new here. But what I would like to do is to focus on some of the real special issues that is of interest to me, which is patient case histories, as well as how we can manage HER2 overexpressed breast cancer in a potentially budget-tight country like Singapore, and of course here in Bangladesh. We are faced with different subtypes of breast cancer in Bangladesh. We are seeing a younger and younger crowd of patients with very aggressive breast cancer, triple negative and HER2 overexpressed breast cancer, presenting earlier and earlier. And of course, there are differences in the survival of these patients. Clearly, also in Bangladesh, we see our triple-negative breast cancer and HER2 overexpressed breast cancer patients not doing as well as they would be in the so-called Western world. So can we translate the data to them? So of course we know that breast cancer, there are four main types, the luminal A, luminal B, HER2 overexpressed, and triple negative. And HER2 essentially is the overexpression of the HER2 cell receptor that defines that one major molecular subtype. And in order to do that, one of the major challenges in some of the smaller hospitals is to determine the immunohistochemistry of HER2 expression. And I dare say that perhaps in the near future, that might be a thing of the past with the definition of a HER2 low and HER2 ultra low. But for the next 20 minutes, I hope to only talk about the HER2 overexpressed. We now know that there are three different subtypes of HER2 targeted agents that we can use to treat HER2 overexpressed breast cancer. We are most familiar with monoclonal antibodies, for which there's trastuzumab, for which there are many biosimilars available now, pertuzumab, and the last one, which is only FDA approved in the USA, but not available in most part of the world. For oral tyrosine kinase inhibitors, we have lapatinib, which again, we see the use of biosimilars. We have neratinib, which is in Singapore considered as an orphan drug, means it's made, but no one really markets it. But there is a rehash of its use nowadays in the adjuvant setting. And of course, there is tucatinib. And then finally, of course, last but not least, we have the antibody drug conjugates, for which we are most familiar with TDM1 or Kadcyla, and TDXD, which is Enhertu. And that's the new kid on the block, and it's going to remain the main actor, I would say, in the scene of HER2 overexpressed breast cancer, both in the metastatic setting and in the early setting in the future. So this is a very nice summary history of what has happened in the last perhaps 30 years with the discovery of the HER2 receptor and the first monoclonal antibody, trastuzumab, in 1998, and the proof that it basically has shifted the survival of our patients with HER2 overexpressed breast cancer. You can see that there is a crowding of different new agents in the last decade with the advent of pertuzumab, TDN1, and TDXD. So let's just look at it from the practical point of view. We hope to cure breast cancer, but specifically we hope to cure the relatively advanced stage 2, perhaps stage 3 breast cancer, the HER2 overexpressed breast cancer. And essentially, I want to focus on assessing the risk and planning neoadjuvant chemotherapy and adjuvant therapy and the treatment strategies. These are not my slides, clearly. There are many clinical guidelines that are Googleable. If you simply just on your mobile phone right now, search up the treatment of advanced non-metastatic HER2 overexpressed breast cancer, much of these guidelines will come out, and it's updated every single year. And in fact, the NCCN guidelines are updated every 6 months. So things are going really, really fast. However, the basic principle remains is that in the last decade, there's been a greater use of neoadjuvant chemotherapy in attempt to downsize the breast cancer and also to determine who are the ones that are going to be the good players and who are the ones who might need a second-line therapy in order to do better in their survival. So I just want to share this slide, which is the NCCN guideline of June 2024 for preoperative or adjuvant therapy, where patients with HR-positive disease are recommended to receive adjuvant endocrine therapy plus CDK4/6 after the HER2 overexpressed breast cancer. However, for the preoperative or adjuvant setting, we can see that the preferred treatment now no longer contains anthracyclines. There's paclitaxel and trastuzumab, TCH, which we're familiar with, docetaxel, carboplatin, trastuzumab, or the addition of pertuzumab if it's relevant. And in the adjuvant setting, of course, if there's any residual cancer, should be TDM1. And of course, they are useful in certain circumstances, is AC, which we know, doxorubicin, cyclophosphamide, followed by trastuzumab with or without a taxane. So it is in a way, our bread and butter chemotherapy would be AC. I dare say that every single medical oncologist that's here right now would know and have given AC before, and I still give AC to many of my patients. Here in Dhaka, AC is really inexpensive. So it is a very powerful chemotherapy, but we're going away from it in the HER2 overexpressed arena. So who should and should not get neoadjuvant chemotherapy? If there is extensive in situ disease, the invasive component is not well defined, the tumor is not well defined, it is multifocal, it is not palpable, not clinically accessible, or patients who are unclear or refuse chemotherapy, or take a very long time to decide on chemotherapy, and patients who are likely to default the surgery after partial treatment, and patients who cannot afford the chemotherapy or other treatments, they should not and never be recommended neoadjuvant chemotherapy. We have many of such patients in my practice, clearly. They will tell you, yes, I'm focused, I will just go for every single treatment. Halfway through the chemotherapy, the tumor disappears, and so do they, only to come back in 5 years' time with a larger tumor that is chemo-resistant. So if I actually sense there is some hesitancy in my patients with regards to chemotherapy, or that they start to say, Doc, this is really expensive, I send them for surgery first. I don't wait to persuade them to get neoadjuvant chemotherapy. Of course, we all know that in the ideal setting in Nirvana, where we have treatment cost is not an issue, we would like to reduce the tumor size, increase the chance that the patient can have breast conservation surgery rather than mastectomy, and of course treat the patient with a high risk of metastatic disease with systemic therapy without delay, and of course to allow the patient to choose what type of surgery they may want. So if I see a patient tomorrow in clinic and they have locally advanced non-metastatic HER2 overexpressed breast cancer, I sound them out. If they sound very hesitant about surgery, I give the chemotherapy first. If they sound very hesitant about chemotherapy, I would send them to my surgeon first. Of course, I would say that there is an opportunity of downsizing the cancer first before surgery and to know the tumor biology, but some of our patients just simply cannot navigate or that type of knowledge. So there are many pivotal studies now on neoadjuvant trastuzumab and pertuzumab for patients, and of course I wouldn't like to go through them because this is all old data. What is more important to realize, of course, is that the differential better response and survival with dual blockade. So I remember, and I have colleagues from my alma mater, National Cancer Center, where we treat many patients who have difficulty with their insurances and for payment of expensive chemotherapy. I remember about 7 or 8 years ago when we started talking about dual blockade and the use of pertuzumab, we said this to ourselves that we were going to bankrupt the healthcare system. But of course now it's the standard of care. And we have the standard of care because we have bioequivalent trastuzumab to help us on that. But we do know that, of course, with dual blockade, there is better responses and survival, even without chemotherapy. So if I have a patient who is elderly and unfit to even walk, but they have a large bleeding tumor that is HER2 overexpressed, I can give them dual blockade with pertuzumab and trastuzumab without chemotherapy, and they would at least have some good response for downsizing for surgery. And what about for differential responses for HR status? We know that the trifina and the CT-NEO-BC pooled analysis have shown that the ER-PR negative, which is the hormone receptor negative breast cancers, tend to respond better to dual blockade than would the ER-positive cancer. Of course, this is, again, standard. We do know that neoadjuvant trastuzumab not only increases PCR, improves progression-free in the long-term follow-up. I put this here because I do still work with many more senior physicians who do not believe in the power of neoadjuvant chemotherapy. They said, well, you know, in my knowledge, whether we give the treatment neoadjuvantly or adjuvantly, patients do equally well. So there's no difference. I see the patient first, I do the surgery first. You see the patient first, you give the chemotherapy first. So why you have to argue and say that you must see the patient first? It takes a little bit of persuasion to our more senior physicians who may not be very familiar with the data, that when we give the targeted therapy in a neoadjuvant setting, it actually improves the chance at progression-free and potentially now we know overall survival as well. So I just want to share some case histories, which are real patients. These are real patients. I didn't make them up. This is a 29-year-old lady with a breast lump for 1 month in 2015. She is still alive and my patient right now after 10 years, but suffering quite a fair bit. She does have a family history of 2 aunts with breast cancer, one known to be a BRCA mutation carrier, triple negative, and the other one is a negative no mutation carrier. She herself tested BRCA2, a variant of unknown significance, and we repeated this test several times in different companies, and it kept coming back as VUS. So she has an ER positive 80%, PR 80%, HER2 overexpressed, stage 2B with lymph node positive by biopsy. She had 6 cycles of PTCH with grosserolin monthly from May 2015 to September 2015. Unfortunately, she didn't have a very good response. She was left with the residual disease, 1.4 centimeters, still lymph node positive, still ER-PR strongly positive, and HER2 still overexpressed. In this day and age now, she would be recommended TDM1. But in 2015, there was no such data. And there weren't no opportunity of putting her into a clinical study. So she underwent wide excision axillary clearance, performed with radiation for local treatment. Until today, I regret that decision. For a young lady like this, I sometimes change my mind and perhaps should have persuaded her to go for a mastectomy with or without recon, because subsequently, of course, her local recurrence made it a difficult task for us to palliate her pain. She continued with tamoxifen and grosserolin, and in May 2017, she had a local breast recurrence. She had a mastectomy with immediate recon, and this time around was an ER 30%, PR less than 10%, and HER2 still overexpressed. I recommended AC followed by PTH, but she was not keen, and she received only AC. She then declined Zoladex and tamoxifen, and in PET-CT subsequently reviewed lymph node positivity in the contralateral side, with the next generation sequencing of the tumor revealing still HER2 overexpressed, but with TP53, TMB low, and MSI stable. The repeat biopsy was ER 20%, PR 0, HER2 still overexpressed with ctDNA positive for TP53 detection. And she went on to do lapatinib, Xeloda, Nevobain, Herceptin. She declined hair loss from subsequently. She then went on to Kadcyla, had a terrible response to that. Had metastases, repeat metastases. We kept repeating the same treatment. She then had tucatinib, Xeloda, Herceptin, and finally she agreed to have an HER2, and she's still on an HER2 right now. Of course, you know, this is an unusual patient to have lived for 10 years with a HER2 overexpressed breast cancer with a poor response at the end. If there will be audience that's sitting with us right now heavily criticizing what I've done, if this was not diagnosed in 2015 and diagnosed in 2022, I think things may have been different. There are so many lessons that we can learn from her. So we know now that this is the standard of care, the Catherine trial, where if there was residual disease at the end of neoadjuvant chemotherapy, they would be recommended, instead of just trastuzumab, they would be recommended TDM1 with a progression-free reduction of 50% in the trend towards overall survival. And to change to the next slide. Of course, now let's move on to the adjuvant setting. Again, we know that adjuvant HER2 positive early breast cancer, 1 year of trastuzumab consistently improves DFS versus observation. And of course, it does also improve overall survival. We know all that. And we do know that no matter how we give the trastuzumab, it is associated with an improvement in the progression-free and overall survival. However, so that's like a thing of the past now. That's a standard therapy. That's bread and butter. That's plain water for all treating oncologists. But how do we build on the use of trastuzumab, additional HER2 targeted therapy in the adjuvant setting? So I mentioned TDM1 in the Catherine trial. And I'm mentioning now trastuzumab and pertuzumab moving from the neoadjuvant setting into the adjuvant setting. Again, I remember telling all of us that we were going to bankrupt the healthcare system, but we're not quite there yet because now we have very good programs from the company that sells pertuzumab. But what's interesting is, of course, neratinib. This is an orphan drug that has now been approved as an extended adjuvant therapy for HER2 overexpressed early breast cancer following adjuvant trastuzumab-based chemotherapy. So we know pertuzumab and trastuzumab dual therapy improves clinical outcomes in early breast cancer with the Affinity trial. And this goes for both the HR positive and the HR negative cohort, but perhaps a little bit more, in my opinion, in the HR negative cohort. Of course, the data does not show that. And this is the ExtendNet, which is a 5-year invasive disease-free survival with neratinib after adjuvant trastuzumab, but specifically more so for the HR positive. So in my patients who actually have a relatively high risk of recurrence and they did not agree to be exposed to neoadjuvant chemotherapy, they will be recommended neratinib. So putting data into context, higher risk HER2 overexpressed adjuvant therapy, we now have 3, the Catherine trial in the setting for residual disease, the Affinity addition of pertuzumab for node-positive breast cancer, and the ExtraNet and neratinib for HR-positive breast cancer. So what about dropping off of anthracycline? There have been a few studies that now show that perhaps dropping off of anthracycline is feasible in early breast cancer. But I'd just like to share yet another interesting patient. This is a 47-year-old lady with invasive ductal carcinoma of the left breast, with nodal involvement per MRI and PET-CT, and the tumor was estimated at a size of 4.6 centimeter by 2.5 by 4.1 centimeter, and core biopsy was invasive ductal carcinoma, and of course the axillary biopsy shows that it was lymph node involvement. It was ER/PR negative and HER2 90% overexpressed, and she received TCPH for 6 cycles with left breast wide excision and left sentinel lymph node, which turned out to be a little of a problem because it turned out that the sentinel lymph node remained positive, and she went on to have an axillary clearance, and she had a residual tumor of IDC 6 millimeters across. 2 out of 3 sentinel lymph nodes with tumor, 1 macro and 1 micrometastases, and 2 out of 31 in total was involved, and residual IDC was still ER/PR negative and HER2 overexpressed. Perhaps if I can show, just have a show of hands, who would repeat the immunohistochemistry on residual tumor at the end of neoadjuvant chemotherapy? Can I show of hands? We don't, because the Catherine trial did not mandate that, and it's actually not right to do so. So as a practice, when we teach our students, we say there is no need to, and we try not to repeat the ER/PR and the HER2 because it changes your mind about what you're going to do. Because the Catherine trial did not have a repeat of the IHC. So why do I do it? In this particular case, so in the previous patient I shared, the patient, this was pre-Catherine trial, so we did it anyway. In this patient, she insisted. She wanted to know if a cancer was still HER2 overexpressed. She was very, very interested in the TDM1 versus TDXD residual tumor Destiny-5 clinical study. However, she was randomized to receive TDM1. So she was rather upset, but that's what she received. She received TDM1, 14 doses, and now she's insisting that she will have neratinib, a niraparib, and she's completed the neratinib. So we don't know because she's still in remission right now. A year post all treatment, we will not know if she's going to do well based on the fact that she had TDM1, even though she had preferred to have TDXD. So I am also tasked to mention something about TDXD. It is able to deliver chemotherapy efficiently to tumor cells as well as their neighboring tumor cells as part of a bystander effect. And we know now this is the standard of care for patients with HER2 overexpressed metastatic breast cancer. But since my talk is on neoadjuvant and non-metastatic, I will mention Destiny-05, which is the key eligibility is early breast cancer with residual disease and or regional lymph nodes following neoadjuvant chemotherapy, and they're stratified and randomized to receive TDM1 as the standard arm and TDXD as the investigational arm. So for a good 2 years, many of my colleagues and myself in Singapore were sending patients into this clinical trial, and we really would be excited to see how this is going to pan out. However, again, I want to share a few more interesting case studies. This is a 52-year-old lady with invasive breast cancer of the left breast in 2020. The BRCA was negative, and she had nodal involvement with tumor size of about 2.1 by 9 millimeters, and a core biopsy, of course, was invasive ductal carcinoma. HER2 overexpressed, but only 30%, and the FISH ratio was 4.2. So she should respond very well to CCPH. She had 6 cycles, and she underwent wide excision and left sentinel lymph node, and unfortunately that also converted to an axillary dissection, and she had a residual primary tumor of 1 millimeter, which for all intents and purposes, it took a very diligent pathologist to find that 1 millimeter, but 5 out of 34 lymph nodes remain involved with residual IDC. And again, this would be open to criticisms. She insisted on the lymph nodes being repeated for the IHC. It turned out to be triple negative. So she had a ER negative, PR negative, and HER2 negative, and she said, no, I will not have TDM1. I will have, because it's not HER2 overexpressed anymore, I will have oral capecitabine, and she continued with pertuzumab and Herceptin. This was patient choice, despite the fact that we had recommended for her to have Catherine. Within 3 months, the disease recurred, and we considered the use of AC dose stents with pH, but subsequently, she went to seek a second opinion, and as I understood it, she received pembrolizumab with oral capecitabine, and subsequently, the disease still came back, and I do not have a follow-up on her anymore. So there are some studies that show that if there is a loss of HER2 positivity, that confers poor outcome. I'm not quite sure if it's called the loss of HER2 positivity or this was a disease that was heterogeneous from the word go. So when we have a 30% only, despite the FISH ratio being 4.2%, I do tell my patients that at the end of the residual disease, we will send for the IHC only for knowledge, academically speaking, for discussion, but the standard of care would be to continue with TDM1, and if the Destiny-05 was a positive study, to TDXD. So I would like to spend a little of time talking about adverse reactions of interest. Of course, trastuzumab, pertuzumab cardiotoxicities are rare, infusional reactions are rare, but the diarrhea can be quite significant in my patients. For TDM1, thrombocytopenia, increased ALT and AST, transaminitis, neuropathy, and intractable hepatic toxicities are rare, but again, we do see it. And for neratinib, we do see an occasional diarrhea and rash, but generally otherwise very well tolerated. So consideration of the management of this induced diarrhea, of course, treatment delay and discontinuation is generally not necessary, but I will share a few cases where I had to end up switching the therapy. So cardiac toxicity, I just want to mention it here because I have some people who criticize my intense repeating of the LVEF, the cardiac function. We do find that some percentage of our patients may have hypertension, may have diabetes, may have high cholesterol, and this is the case here in Dhaka. In Bangladesh, we see a number of ladies in their mid-age, 40s to 50s, already developing high cholesterol, high blood pressure, and diabetes, and therefore they are at a higher risk of the cardiac toxicities from dual therapy, even if they didn't have anthracycline. So I just want to talk about de-escalation, managing lower risk early breast cancer, where we do now see a percentage of our patients who present with tumors that are node negative and less than 3 centimeters. And of course, we know that despite the small size of the tumors, there is still a risk of recurrence. And we're recommending chemotherapy to tumors that are smaller and smaller and smaller. And now we're recommending chemotherapy to patients with even 0.5 centimeter of a T1A to B and 0M0 breast cancer. And I just want to, again, share some interesting cases. This is a 42-year-old lady with invasive breast cancer. And she had multifocal tumors. She had a ER positive, PR positive, HER2 90%, and I gave her TCPH, and she went on to have sentinel lymph node biopsy, and this was a complete response. With her, because she had a complete response and she had a lymph node that was negative at the beginning, post-surgery, she asked me this question: do I have to have pertuzumab? It is awfully expensive. So she went on only to have trastuzumab, esomastane, and grosserolin, and she's doing very well with no recurrence. So this is another lady who had intolerance to chemotherapy, 41-year-old IDC, no nodal involvement. Core biopsy was a grade 2 IDC, ERPR positive, HER2 30%, and axillary lymph node biopsy negative. She didn't even go on to finish 6 cycles of TCPH. She had grade 3 transaminitis, neutropenia profound, mouth ulcer, severe diarrhea, several times on stopping and restarting treatments. Eventually, she just wanted to give up, so I said, fine, let's just go for surgery first. So she had a 1.6 centimeter residual tumor, not unexpected, given the fact that she did not complete her treatment. But again, I said to her, pre-surgery, we are going to check the ER and the PR. Again, this is off protocol because I would have recommended you to have TDM1 anyway. But let's just see what is left. And she had an ER/PR positive, HER2 0. So post-surgery, she obediently received TDM1. Of course, she did say to me, but doc, there is no more HER2 in my breast. Why do you have to give her TDM1? Because I said, we're following protocol. So again, to TDM1, she had grade 3 transaminitis, neutropenia, profound mouth ulcer, severe diarrhea requiring admission. I think she has exquisite sensitivity to the docetaxel. So she's just gone on to have Herceptin alone. So dropping off pertuzumab after neoadjuvant chemotherapy in a situation, in my practice, whether it's controversial, if they have very severe complications for pertuzumab, or if costs are a real concern, and we do know that they're lymph node negative to begin with, we can drop off the pertuzumab. What about elderly patients or unfit patients? As I mentioned, even if we were to give dual targeted therapy without chemotherapy, they tend to do very well. And of course, we always quote the APT trial, the adjuvant paclitaxel trastuzumab for small node-negative HER2 overexpressed early breast cancer. Prior to the publication of this particular clinical trial, we were already giving these patients, but telling patients there is no data to show that you will do well. But your disease is so small, I can't bring you to have big and critical chemotherapy like anthracyclines or carboplatin and docetaxel, and this is what they had. And I would dare say none of my patients have recurred. So what about less than 1 year of Herceptin? Many studies have shown that less than 1 year is not non-inferior to 1 year, so 1 year remains to be standard. And I just want to share this because now, of course, we're looking at the use of TDM1 instead of chemotherapy. So for some patients who are adamant about not losing their hair in the adjuvant setting, this may be of consideration in future, and this is my lovely hometown. Thank you very much for your attention.